Wow, Ketofest, the best conference that combines music, food, socializing, and science. It typifies what the keto dudes had and have created, which is the combination of super cool and keto and geeky all together. So it's my pleasure to be here. Thank you, Carl. So now keto reversing heart failure. I guess if you're new to low carb or keto, it's basically published now for years that keto reverses obesity. And I've given that talk, oh my gosh, look online many, many times now. Keto reverses diabetes, published papers, and Sarah Hallberg being part of the Verda Health study, great science published, and it's basically published and everyone knows about reversing diabetes and obesity. And in my office, I have two handouts that I'll bring in. I work at Duke University, and one is the Banting Diet book from 1863. That was the first diet book ever. It was a low-carb diet, the Banting Diet. And so I have this old book. Someone says, oh, it can't do keto, can't do low carb. I'll pull this out and say, well, it's really not new, at least the version I teach. And then from 1923, this approach was used to treat diabetes in the book. And I have the actual pages from the book. And I was looking, wow, these pages are 100 years old now, almost, because it's actually from the book. So this keto reverses obesity, keto reverses diabetes. Everyone knows that. What nobody knows is keto reverses heart failure. And so what I learned over the last couple of years without conferences is, we need to start getting information out and driving the academic world. And while I used to be someone who wrote and published research papers, I'm now doing research in my clinic, basically seeing things that the academic people are not even studying yet. So we're way ahead of the academic researchers, and we're trying to stimulate that research. So my talk about obesity, about diabetes, those are all online. Please check them out. Today I'm talking about heart failure and about the heart in general. So let's see. My conflicts I don't have on here, but or my involvement. I work at Duke full time. Really, I'm an associate professor with tenure there at Duke, and I also have a company called Adapt Your Life Academy, that teaches people online how to do a simple version of keto now. Yay! So we have some Adapt Your Life Academy members in the audience. Thank you, and probably watching as well. So I'm going to, spend the first part of the talk just talking about what the heart does. So it's nothing to do with keto. It's not controversial, and it was a good review for me, and a good, hopefully, review or first-time look. It's a pretty complicated thing. So I can make three different big categories when I talk about the heart. So if I say the heart gets better, I have to address these three things. The first one being the heart muscle or the pump. That's the atria, the atrium, left atrium, right atrium, and the ventricles. That's what most people think about when they think about the heart, unless you're talking about heart attacks, and that's number two, which is the blood flow to the heart. So the coronary arteries are involved in a process called atherosclerosis, and if you get narrowing there or blockages, that's what typically leads to a heart attack, which would be a loss of blood flow to the heart muscle. So we're really talking about two processes there. We have the muscle itself, and we have the blood flow to the muscle. So you might be able to fix one and maybe not the other. Well, then there's a third thing. What about the coordination of all this together, which is the really kind of an electrical system coordination, and that's where you get arrhythmias, skipped heartbeats, things like that. And so it's really a great system. I'm an internal medicine specialist, and I went through training in cardiology some years ago, but as an internal medicine and an obesity medicine practitioner today, this is fundamental to my practice to know about this. So first, let me take this I think now is in the 5th grade education for most kids, that there's a circulatory system. And the fascinating history about that is that people like you and me didn't know about this until relatively recently. It was assumed that the tide, the blood went out and then came back, blood like out and back. But to know that it's a circulatory system was actually relatively new to figure out. And so you have all blood is not blue and red. It's all red, okay? That funny little thing there. But we show it as blue blood to show that's the venous system. So on the left side here, you have the left ventricle with oxygenated blood in red. It's coming from the lungs, and it gets sent out to the organs, and then it comes back deoxygenated, but it's not blue. And then it goes to the lungs where it gets oxygenated again and goes back to the heart. So I hope you've kind of seen this before or relearned it as your kids went through middle school. And then the detail, okay, there are some valves that make sure it goes in one direction as best as possible. And there's sort of a 1-2 lub-dub sort of function where the little pumps get to the big pumps. So that's the atrium and the ventricles. So it's all coordinated like that. Pretty amazing. So there's a percentage I want you to remember, and that's the ejection fraction, or EF. If you've ever had a echocardiogram or had a family member have that. So the heart doesn't totally contract down to nothing, like my fist here. It will contract and there'll be some blood remaining in it. And the ejection fraction is the amount of blood that's actually pushed out with each contraction. And a normal ejection fraction is 55%. So the heart basically, like half the blood gets sent out on each beat, okay? Just keep that in mind, 55%. The percent of blood pumped per contraction. So a heart attack is a sudden reduction of blood flow to the muscle itself, oxygen being the main thing that's needed. So if you have chest pain or tightness or like an elephant sitting on your chest, that's the feeling of insufficient oxygen to a part of the heart. It doesn't tell you how much the heart is at risk, and so it's a kind of not a great accurate predictor of how much heart is involved, but that's the warning sign that you feel. And so here is actually the combination between the blood flow to the heart muscle itself and the muscle itself. So that's the heart attack typically will have a blockage or a blood clot on top of a cholesterol plaque or whatever sort of blockage there is. It could be spasm. It could be just a brief spasm of the artery and then it goes away. And then some of the heart kind of cries out. And if you can't get blood to it, it might die. And you have had a heart attack that is not repairable, apparently. So some of this process is reversible. Some of it's not, right? So what we want to do is make sure there's plenty of blood flow. And now we're getting to how do you get blood flow to the arteries of the heart through the arteries. And so this is sort of a see-through picture of the right coronary and the left coronary, and it's just because that's where it goes. And then we're looking at the body and face. So the right side of the body is on the left side of the screen. I know it's kind of weird and to see it that way, but the right coronary goes around the heart to the back. The left coronary goes around the heart to the left and around the back. And then the left anterior descending, or LAD, comes around the front. Left main is also known when there's a blockage there or a total occlusion as the widowmaker. Because you can see here, if you block the left main artery there in the middle, you basically block the left circumflex going around the back and the left anterior descending. And that's the left ventricle that pumps out to the body. And that's the, basically the heart stops beating. If you don't get emergent medical care, most people will become widows or widowers. So it's called the widowmaker. You may have heard popularized a movie, I think of the same name, where they man found that he had a widowmaker lesion, meaning a blockage there, by doing a coronary artery calcium score. And so they recommend everyone get coronary artery calcium scores, which has caused this terrible misunderstanding and misinterpretation of this test. But if you have no symptoms and you get a score that shows that part of the heart has some calcium, it might save your life. And that's what the movie basically said. Everyone should have this, because if you have this, I don't know how common it is, but that was the impetus to get that movie, and then the popularization of getting coronary artery calcium scores. But this is so these are the arteries that take the blood flow to the heart muscle. But that's not what it looks like to a doctor. This is what it looks like. I thought, now I'll show you what an angiogram looks like. So this is the X-ray view of, on the far left, a total blockage, because you can see the flow stops. So it's actually dark. The blood flow is dark. And then the artery is opened, and then you get blood flow to the entire rest of the artery there. And then on the right side, just to show you how imprecise this is, these are blockages, which is the white pushing into the black area. And so a human or a computer gauges how much blockage there is, based on these sorts of pictures, not the stylized pictures I saw you or showed you from the cartoons. So, they measure the amount of blockage as best they can. And if you go from 100 to 0 blockage on the left, it's pretty easy to see. If you have a minor blockage or just something that's not total, it's kind of hard to see sometimes. So it's not a perfect test, is really what I'm trying to say. Even today, back when I trained in the 1980s and 90s, the urgent need to open an artery that was blocked in the heart it still persists today. So before they used to use balloons, and now there are balloons, and so the balloon catheter in the middle. Now there are roto-rooter devices and all sorts of things. So the main thing you want to do is open the artery and get blood flow to the heart, right? Does that make sense? And then very commonly, even at a place like Duke, if you have a narrowing like this, they'll put in a stent, which is kind of like a Chinese finger torture sort of apparatus, where you put it in and open it up, and it keeps the blood flow open, of course, until the atherosclerotic process narrows the stent. So it's not a perfect solution to it. But the idea is, if you have a lack of blood flow to the heart, you want to open the artery. And the reason I'm giving you all this is that these are really two different processes. The atherosclerosis that affects the coronaries, and then the heart muscle itself. Because I'm going to be talking about heart muscle failure, not coronary artery blockage, which you might not have realized at first. And then the final thing is the coordination of all of this, which is really more like an electrical system. And one of my friends went into electrophysiology, and basically he's an electrician of the heart. And they map out all of the electricity and procedures that often last all day to figure out the electrical activity of the heart. You might have had an ablation or some sort of manipulation to change that electrical flow. And this just shows the conduction system up in the atrium on the left. The SA node, it's called the sinoatrial node, starts the signal, and then it gets picked up by this atrial ventricular node, and then that electrical signal goes out to the heart to then have a symmetrical kind of contraction. And so now we're talking about nutrition and good health of the conduction system as well. So we're talking about heart muscle, the blood flow in the arteries, and the conduction system, all meaning this is the heart, right? If you ever have on the bottom right of this slide, I'm sure you've seen on TV, a flatline EKG, but you're eating dinner, don't let them come in and do CPR on you. It's usually because the lead has fallen off. This is for health people. So on the upper left is a normal EKG, and you can get this on your watches now, right? And your EKG can show you things in the middle, which are atrial abnormalities and conduction abnormalities, and ventricular abnormalities on the far right are the ones that lead you to go to the ER or have a shock or CPR. And the one on the bottom left is called a PVC. And you really can't tell if it's from the atrium going like, offbeat, or if it's the ventricle without an EKG. So if you're having palpitations, skipped heartbeats, you feel that it's skipping all that, you want to get an EKG run to just give you an idea of what it is, or have your watch tell you. The watch actually, at least mine, says that you don't have atrial fibrillation, basically, but I can't tell you anything else. And it says if you have chest pain, go to the hospital. Yeah, my watch tells me that, right? So, but so this is all the heart function. How could keto be good for the heart? Well, I've had several patients now on a keto diet whose heart conduction system had failed, but they had pacemakers. So now you can put in a pacemaker, and they're pretty, it's called an artificial pacemaker, because if it's your normal pacemaker, one in the heart is called a pacemaker too. But now I don't have to worry about the conduction system really, because if the heart doesn't beat by itself, this electrical system will kick in. And so in my mind, okay, I'm doing this crazy no-carb diet thing, and oh, there's a pacemaker. I don't have to worry about the conduction system too much, And even if the pump fails, I've had several patients now, and the heart transplant program at Duke likes me because I send them people lighter, and then they can do transplants on them, because many people now are in line for a heart transplant, but they're too heavy. So I'm the weight loss guy for the heart transplant program informally. They don't pay me anything. But so if the pump fails, no problem. We'll just put in a pump to replace the function of the heart, the pump function. So this is called an LVAD or a VAD. There's someone else here today who's working with another program at another clinic. It's okay. Now I don't have to worry about the pump part of the heart, or even the electrical system part of the heart, because the pump is doing it all. Now, these are the folks who I can have a student or a resident come in the room and say, I'm having trouble getting their blood pressure. Can you please check it out? And they'll start to check the pulse. And like, doctor, there's no pulse. These are people without a pulse, because this is a continuous flow pump. And they're walking around. And then, of course, one resident comes in, he's got a battery pack here. He's got an LVAD, because there's so many now at Duke. It's a big center for the ventricular assist devices. They need to be on anticoagulation, because this material will develop clots. So you have to be very careful about vitamin K intake. Vitamin K antagonizes Coumadin. And so people are sent home now with an anticoagulant monitor, so they can check it every day. It's that imperative to keep the blood thin. So there's the coronary arteries. Okay, they're already blocked on these folks, right? And then the conduction system, I don't need to worry about that, because this pump is taking care of the heartbeat, and it's a continuous flow. It was a little unnerving the first time I met a fellow with an LVAD. He said, I need to change my battery, doc, in the room. I was like, wait, what are you doing? He said, no problem. It took 2 seconds to just change but that meant there was no blood going around then, And yes, when they go for a transplant, they take it all out, put the new heart in, and then you're on anti-rejection drugs for the rest of your life, basically, sometimes prednisone, which makes you gain weight, and all these other things. So it's no cakewalk to get a heart transplant. And then a lot of these are left in temporarily for years because they haven't found a heart yet, or they're too heavy to be transplanted. So there's a term to have it a bridge to get a transplant, or you just are keeping it in to have them live longer. But no problem. All I do is change the food, right? As an obesity medicine doctor, I don't give medicines. I don't do surgery. All I do is change the food. It's pretty neat. So to the cases. Okay. So just setting the state. Now you have good knowledge about what the heart is, what you need to worry about, or what I worry about with the heart. This is a 43-year-old female. If its BMI is 55, and that's just the weight and the height adjustment there. She had heart failure. No one really knew why. So she came in short of breath. Just about everyone gets a defibrillator put inside now, so that if the heart stops, it automatically shocks you. It's a pretty interesting thing. Initially, she lost weight watching calories, but she hit a plateau. And that word of mouth thing, her father was doing this keto. Have you heard of it? It's keto diet. So she did some internet research where everyone goes to learn about the keto diet. Well, use real food, please. And she lost 15 pounds, but then got stuck and then ended up in my office. So looking back, so here where she had the heart failure episode in blue in the middle here, she developed obesity as a child. And at 33 years old, she weighed 250 pounds on the far left. She lost weight and then regained it, and because no one taught her how to sustain the weight loss. So she had heart failure at about 300 pounds, and she's 5'2". So you don't really need to know the BMI and what that is. This is, she's large. It's very possible that it's the obesity that caused the heart failure. Nobody had a diagnosis. She didn't have coronary disease. And what happened over time, you can see the weight, this is the weight going down, the diet, however you reduce calories in a way, low carb lowers hunger, you eat less, that's how it works. Here are her values for her heart function at the bottom. So weight is one thing. And the heart function at the beginning there, when she was symptomatic, was 20%, the EF. So it was about half the normal function. She had very severe symptoms, ended up in the hospital. Got better with some, over time, down, when her weight was down to about 270, the ejection fraction was 35%, but she was still symptomatic. And so she came to see me. She got all excited about it. She's an ICU nurse and had medical background and all that. And now, just recently, she's down to about 180 pounds. So she's down about, 130 pounds. And her ejection fraction on the echocardiogram is 50%. It's almost normal. Very few papers published about heart failure getting better with weight loss, however that you do it. Now, you can lose weight with surgery, with medications, things like that, but this is just changing the food. In fact, eating great food. Did anyone have the brisket yesterday? So, a doctor talking about food and meat and brisket. Oh, yeah, that's right. That's what keto is. So, she has a Instagram, of course, like everyone. She has an Instagram and tries to teach other people about this. Okay, so lightning can strike. And this will happen if you're starting to use this with another doctor. Well, okay, someone came to your clinic, they got better. Yeah, okay. The second time, maybe there's something to it. The third time, everyone gets sent to my clinic from that doctor, right? Because you can ignore it, and especially if the patients come in the same week. That's a great, transformative educational experience. They might not remember if they came every 6 months, But so this is a 62-year-old African-American male with heart failure and EF of 25% on the very bottom there on the left. And he had actually had a sleeve gastrectomy, which is where they cut out 2/3 of the stomach, make it like a banana. They take out that part of the stomach, and he lost some weight but then regained it because nobody taught him how to keep the weight off. And that's a big problem with programs that help you lose the weight but don't teach you how to sustain it. But keto is great for that. So he's back all excited. He was depressed. Now he's got a job and is a consultant and loves this. And now his EF went from 25% to 42%, which is huge. I mean, you don't see this kind of variability And oh, it's a number, no, and his function is normal now, what he can do. Remember, he's got coronary arteries and he's got heart muscle and he has a conduction system and he still improves his EF like that. Okay. Now, I don't know if it's the weight loss. Perhaps you put someone on medicine for weight loss and they lose the weight and their heart will get better. Well, while I'm thinking about this, one of my patients comes back, she's 76-year-old, and someone said that this meeting, oh, well, my parents, they're 72, they can't do that. Oh, yes, they can. There's no upper limit of age where you can change the food to real food. That's really all this is. So this non-ischemic cardiomyopathy means it wasn't the coronaries. They went in and the coronaries were normal. Those arteries were normal, but the heart was in failure. Well, she had complete heart block, meaning like that, almost like that flatline EKG. Her heart wasn't beating, so she had a pacemaker in. But the pacemaker had been in, about 10 years. So I don't have to worry about her heartbeats. They're going to be at the same time, but the heart isn't functioning well. And actually, I picked up some data when she was weighing 250 pounds or so, between 225 and 250. Her EF was documented as 55% twice on the echocardiograms. I'm not going because she had echoes because of the conduction system problem. The heart pump was just fine. But over time, the ejection fraction went down to 35%. And she got on the keto diet and has lost and maintained about 50 pounds of weight loss, but her BMI is still 31. And normal BMI would be 25 to 23, somewhere in there, maybe even 21 if you're young. But she's still classified as obese, and yet her ejection fraction is now back up to 55% without that massive weight loss from before. So is it the weight loss? Is it the keto diet? Is it some magic of ketones? I don't know. We need to study this further. And the reason we need to study this is it all makes sense. Are you ready? Heart muscle is mainly fueled by fat and ketones a little bit. So here is a study showing the pie chart, the gray and the yellow, if you add them all together, is basically the total fat consumed by the heart muscle. And this is why I'm making that big distinction. The heart muscle runs on fat and ketones. Glucose doesn't even show up on this pie chart. It's not used by the heart. Although, if you talk to radiologists who are infusing radio-labeled glucose, they say the heart lights up. And then when you go on a keto diet, the radio-labeled glucose doesn't light up the heart anymore. I think they're picking up just a very small amount of glucose metabolism. But the heart runs on fat and ketones. And to the shock of, here, just in larger, I think that, I don't know if it's cognitive dissonance. I think Richard Feynman pointed this out years ago. Cognitive dissonance is where you have trouble you hold two contradictory things and it causes some weirdness in your behavior because you really have right and wrong. And they couldn't say that the gray and the yellow was all fat. They had to separate it out because, you couldn't just add it up and say 80% of the heart was run on fat. I mean, they couldn't, right? Couldn't come to that. Oh my goodness. Because, in the abstract and in the paper itself, here's what they wrote. And this is 2020. Now, I met with researchers and physiologists in the generation before this one, and they all knew the heart runs on fat. You put heart muscle in a petri dish and it sucks up the fat and the ketones and it just looks and thumbs its nose at glucose. So here in 2020, in the abstract of this same paper where that pie chart comes from, unexpectedly little glucose. So the sentence there, the heart primarily consumed fatty acids and, unexpectedly, little glucose. This is the paradigm we're in. even in the physiology world, this is 2020. The heart runs on fat. Now, that's the heart muscle. When you're talking about coronary artery disease, that's the process of atherosclerosis. The cholesterol, all that story, and you're hearing that kind of unravel. It's more complicated than we used to think. But this is fascinating. They were shocked to find out that the heart ran on fat, but the heart wasn't shocked. The heart has always run on fat. And this is a theme that comes through the treatment of obesity, diabetes, and the treatment of heart conditions and heart failure, and probably atherosclerosis, although we're waiting for great data on that. The paradigm is just glucose-centric, and really the heart runs on fat. So this is still a concern. What about the keto diet and the blood flow of the coronary arteries, right? So, okay, all right, Westman, the heart runs on fat. But what about those arteries? Oh my God, you know, and I'm using sarcasm and hyperbole here, which is not a good fit for me. Something about the last 2 years drove me stir crazy. So cardiac muscle may be fueled by fatty acids and ketones, but what about the atherosclerosis and the causes of coronary artery disease? Well, there's a shift going on called a paradigm shift, and a lot of doctors don't know about it. Most researchers know about it, but then the second bullet, metabolic syndrome or insulin resistance, is implicated as the major risk factor, if not, the major risk factor for atherosclerosis and coronary artery disease. And so now it's well known in the literature that metabolic syndrome and insulin resistance is a cause of heart failure. Heart failure is in the literature, but so if insulin resistance causes heart failure, what possibly could fix insulin resistance? Well, there are no good drugs for that. Well, there is one now, but it causes ketoacidosis and infections of called Fournier's gangrene. You be careful of these SGLT2 inhibitors, but the keto diet reduces cardiometabolic risk by addressing the metabolic syndrome and insulin resistance. So you can kind of see the dots here. Well, most cardiologists don't really know about food other than, don't eat fat or bananas have potassium. I'm not worried about the coronaries, but I know other people are. And research is going on, thanks to Dave Feldman and his group. That's going to be a great study to watch. What about the conduction system? And so arrhythmias can be serious or they can be benign. And most of the time they'll be benign. But there was a paper some years ago of remember Barry Sears and the zone diet. I remember I talked to Dr. Sears, and said, how do you measure if someone's in the zone? He said, well, you measure these eicosanoids. And I said, oh, those are kind of fleeting. They come and go. Can you really measure them? Oh, no, you can't. So, but you're in the zone, okay? We want to have something that's measurable. But in their paper that I think had 10 people, one person had palpitations on the low-carb diet, so they dropped that person. Palpitations are not a serious arrhythmia, probably. Actually, palpitations can happen with fluid volume shifts. And I think that's what most people will feel in the first week or two of changing because the fluid volume changes. But I don't know that for sure. In fact, there's some anecdotes that atrial fibrillation might occur after changing the diet. Well, remember, you're using a very effective kind of diet. It's changing lots of things, and weight loss is happening, fluid volume's changing. There was actually a study in that fourth bullet down that atrial fib was associated with lower carb intake in this large study called the ARIC study, ARIC. But the problem is the lowest carbohydrate intake was 37% of the daily caloric intake, which is not what we would call keto or even near a keto diet. But I have to say, it's a potential problem. Not a whole lot of studies about the conduction system after you go on a low-carb keto diet, although my cardiologists who know about this program at Duke have no problem with it, especially if they have an LVAD, You don't have to worry about the conduction system or the arterial system. You're really just, helping with the pump. So if there is a problem like this, it's an infrequent one. And now we're in that space of, until you have comparative trials of effective weight loss approaches, you won't know if this is any more common than it is with other approaches. You understand that? So if you don't have a randomized trial can help, and you're figuring out if something is better than another in terms of efficacy. And also a randomized trial can tell you if something has more side effects than another, but you have to have that kind of comparative trial to know if it's a low rate of something like this. So wrapping up, hope I showed you a little bit about the heart, for non-technical people. I hope that was informative. Hope you don't have to ever learn any more detail than that. You don't have a problem with it. So we have noted 3 cases at least, and I'm just putting together the LVAD experience of the people I've had. I off the top of I've sent 4 people for transplant just by looking, and I don't have the other people assembled yet. Of course, as you saw, that really intensive intervention, the LVAD is that implantable pump. Actually, a lot of people will get infections of that line and actually die because of infection, nothing related to the heart itself. So, I'm humbled. If you meet doctors who say, "Oh, this fixes everything," blah blah blah, suspect that maybe they're not taking care of patients or taking care of sick people. The other thing I wanted to get across is that I take care of people who are really sick. There are diabetes and obesity and hypertension. That's like bread and butter now. People come in on 3 medicines for each one. 3 medicines for diabetes and probably injectables, and then 3 medicines for hypertension, and that add on arthritis pills and all that. And I get to take people off those medicines carefully with monitoring, of course. Of course, clinical monitoring is recommended for anything like this. If you have heart failure, please just don't try this on your own without some sort of assistance. Of course, we can't say that it's the keto diet by itself that led to the improvements independent of weight loss, although the 3rd case of the woman who only lost some weight and then still improved her heart function makes me wonder does the heart like fat? Does the heart like maybe that years of getting the metabolism right can help, even if there isn't a lot of weight loss? I think that's pretty exciting, actually, that the salutary potential of ketones, but that's still a hypothesis. So then the next bullet, the 4th one, a review of the fuel use of the heart, like we did, and underlying causes of coronary artery disease is reassuring that this approach will be safe. So we kind of ticked off all of the check boxes to strongly urge cardiologists and other researchers to consider the keto diet in their clinical and research efforts for heart failure. And if it was shown in that abstract, the current state of affairs is that heart doctors still think the heart uses sugar and glucose. That's pretty sad. But there's opportunity, and spreading the knowledge here in a grassroots way has made a lot of progress. I have to say, since the pandemic, there haven't been a lot of conferences, but a lot of people have gotten better because they cut the carbs out of their diet. Now, my company, Adapt Your Life, and Adapt Your Life Academy is putting on a no sugar challenge. So if you need help getting off sugar, please go to the adaptyourlifeacademy.com and click on the 10-day no sugar challenge. And what we're doing is we're putting all of our internet support resources into a Facebook group where you get in for 3 weeks to get off of sugar. And we're doing it all for free. And if you are having trouble getting off sugar, you have a loved one, actually we're challenging everyone in our ongoing support group to get just one family member or friend to just try out the no sugar challenge. So many people feel so much better, and it can be sort of the first step toward a keto kind of lifestyle. Now, how many of you have had family members or relatives who just won't do this? Everyone's raising their hand, of course. So the no sugar challenge is a way to get a little toe in the water, so to speak. Again, my pleasure. The overview of the heart. Let me just spend 1 minute on that. Just to remind you that if you're talking about the heart, you're talking about the heart muscle. You're talking about the coronary arteries that are supplying the heart muscle, and you're talking about the coordination of the contraction, which is really more like an electrical system. Now, I didn't talk about the fuel utilization of electrical systems. That's called the brain. Oh, wait, has anyone ever talked about how the brain likes ketones? Yes. So that world, the brain researchers, the Alzheimer's researchers, minimal cognitive dysfunction, are doing research studies now with keto, and they're dealing with one, big nerve, well, a bunch of nerves, the same kind of nervous system. So the nervous system can run on ketones as well, but again, that's theoretical. But when you're talking about a heart, you want to consider all of these three things. Thank you.